To today's program. I'm Molly Gamble, Editor-in-Chief with Becker's Healthcare. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Alicia Torrance is the Senior Vice President of Clinical Operations of Surgical Directions. Alicia has over 33 years of experience in perioperative clinical, medical, surgical, and critical care nursing, as well as nursing leadership in both for-profit and non-profit health systems. As former Senior Vice President of Clinical and Marketing Services at a major medical device manufacturer, she was responsible for providing clinical direction, program development, clinical consultation, and clinical quality review for perioperative services in hospitals and surgery centers, as well as education and training of perioperative clinicians. Alicia is Lean Healthcare certified and is completing her MSN. Jeff Peters is the President of Surgical Directions. Jeff is an experienced healthcare business strategist. He has over 25 years of experience working with physicians and hospital executives in a collaborative manner to optimize perioperative services. Jeff is adept in addressing the operational, financial, and political issues of most hospital systems, from the small rural community-based hospital to the large, complex, quaternary academic medical center. He has worked with hundreds of surgical and anesthesia departments and understands the complexities and importance of these services to an organization's financial performance and reputation. It is now my pleasure to turn the floor over to Jeff to begin today's presentation.
Well, thank you. So first of all, we want to thank all the participants for taking time out of their busy schedule to listen in. What Alicia and I are going to do is to basically talk a little bit about why perioperative services are important to any hospital or health system, and then go through a very practical approach that you can use in your own organizations to identify opportunities for improvement and then to begin to act on these opportunities, so that the goal will be to give you tools that at the end of the session you can actually use to improve the performance of your organization. So to begin with, I think what's important is to understand why we, as healthcare leaders, we really want to even focus on perioperative services. And the reason why is in better performing hospitals or health systems, over 68% of the margin is driven by perioperative services. So even as we move towards a value-based system, it's really important that we understand what's driving perioperative services, how we can go about growing them, and how we can really structure them to ensure that we have the best clinical outcomes. Next slide, please. What's really important is within perioperative services, as all components of the healthcare system, is to begin to really look at how we can drive value for perioperative services. And value in terms of perioperative services, like most services, is really measured by improving clinical outcomes and making sure that as you divide those clinical outcomes by cost, you have the highest value. And what we're going to talk about today are some of the governance models, some of the key components that not only improve clinical outcomes, but help you to lower the cost of operating your perioperative services departments. Next slide. In looking at over 550 healthcare systems across the country, we've really found that systems that have the highest level of surgeon satisfaction, highest level of patient satisfaction, and highest outcomes, both clinically and financially, typically have certain characteristics. And we'll explain this in some of the case studies. But the first characteristic is that it has a collaborative governance structure. There isn't a single individual running the OR. It's no longer run just by the OR nursing director, but really hospital leadership in the form of administration, anesthesia leadership, clinically active surgeons, and nursing come together to say, what is the vision for perioperative services in our organization, and what operational systems do we have to put into place to achieve this vision. And what drives performance after this governance structure more than anything else is providing information. 50% of all the problems in most ORs can be solved by just giving surgeons or key individuals information, both on clinical performance, on how their cost compares, and particularly surgical case time for the surgeons. And by giving information and by having people come around to the table together, it really allows physicians, nurses, and administrative leadership to feel that they have an impact and that drives performance. Increasingly, there are innovative models that are proving to have incredible impact upon clinical outcomes and cost. Surgical home, which we'll spend some time talking about, and that's in addition to the standard things that most surgeons are focused on in terms of turnover time, on-time starts, and case time. But what really drives an organization, and if you walk into an OR within 5 minutes you can pick it up, is everybody focused on clinical excellence and doing everything possible to both improve clinical outcomes and efficiencies, or is it an organization that really is resisting change? Organizations that are successful are never satisfied with how they are, and in a constructive, collaborative way go about pushing each other to get to the highest form of clinical and operational excellence. If we could have the next slide. Another key component in driving this is anesthesia. Anesthesia is sort of the glue that holds an OR together. They have the same incentives as a hospital. They want to have high quality, they want to have low cost, and they want to have efficiency. But they have that ability, because of that physician after their name, to really relate well to surgeons, and they're in the room. So organizations that excel have a high level of both anesthesia leadership and a commitment on every individual within the anesthesia team to driving performance. Part of what drives it is that they work on a proactive level to really manage the OR schedule, and we'll talk about that a little bit later. But anesthesia's participation in a daily huddle, where you're looking at your cases 2, 3, 5 days before surgery and thinking about, is that patient optimized clinically? Do we have the right staff in the room? Anesthesia can show their commitment by doing that, in addition to focusing on PAT and some of the other things that we'll have some comments to talk about. But everything on this slide are components that you would want to have as part of your anesthesia contract and performance standards, so you know that anesthesia is aligned in terms of the hospital in driving performance. So let's go to the next slide with a case study. And this is an actual case study that Alicia helped to lead. It is a tertiary hospital, Memorial Regional, in Hollywood, Florida. And when we first had the opportunity to look at them, they were really underperforming clinically, financially, and operationally. And the CEO was a little reluctant to really talk about a new model for delivering and governing perioperative services. And I think it took a lot of courage on his part to say, you know, if this is going to get better, I really need to look at this in a much different light, and he had the courage to do it. So if we can go to the next slide, this is a dashboard, and I would suggest that this is a dashboard that anyone on this call can use to sort of at a high level measure the performance of your OR and to really look at whether or not there are opportunities to improve. So what we've got is the metrics in the far end, left end of the dashboard, what we would view as the benchmark for optimum performance, and then here we're going to talk about how Memorial lived up to the benchmark. So the governance body that you want in an OR is what we talked about before, where anesthesia, surgeons, nurses, and administration come together to establish a vision for the OR and how they're going to do it. It's basically operationalized with a multidisciplinary daily huddle. You really want to do it early in the afternoon for a 60-room OR. There should be no problem in getting through all your cases in less than an hour. If it's more than 60 rooms, sometimes you might want to have 2 huddles and divide them. But again, everyone's participating. In this case, the only one proactively looking at the schedule was really nursing. There was no daily huddle at all. And in terms of governance, the anesthesiologist leadership and nursing leadership could not be in the same room at the same time. There was a great mistrust of one another, and if that's going on in any organization, it's difficult for the OR to function optimally. In terms of the block schedule, increasingly there's a lot of evidence, empirical evidence in the literature that talks about the fact that you want most of your blocks to be 8 hours. You want a minimum of 75 or 80% utilization to maintain block. And in a future slide, we'll talk about why. Like many organizations, this hospital had 8-hour blocks, and it also had 4-hour blocks. If a surgeon wasn't meeting their block utilization, rather than taking away the whole block, they reduced the block, and that doesn't breed efficiency. In terms of cases in the OR, the most accurate way to look at your OR utilization is looking at actual case time, but turnaround time. But a very good, quick benchmark of that is measuring how many inpatient and outpatient cases you're doing. If you're a quaternary or tertiary facility in an OR, you should be doing about 900 cases per room per year. In a more community hospital, it's more like 1,000 cases per room per year, excluding cardiac, and for outpatient, anywhere from 1,300 to 1,400. So you can see with a case mix here of 40% outpatient and 60% inpatient, they should be doing about 1,100 cases per room. They were doing 900 cases per room, and that sort of gap of over 112 cases a room has a huge impact upon hospital revenue. It has a huge impact upon your utilization of your nursing staff, and it's very difficult for anesthesia to cover their costs without that level of volume. And when 75% of all hospitals are giving anesthesia some sort of a subsidy, you want to make sure that there is relatively high utilization per room. Cancellations, the benchmark is less than 1%. Within 5 minutes, we can see that this organization had a 5% cancellation rate. Turnover time was high. I've certainly seen higher. And then another measure of efficiency and whether or not your pre-anesthesia testing is working well are 90% of your cases starting within 5 to 7 minutes. We can see here it was only 50%. So in a lot of metrics, you can see this organization, like most, had an opportunity for improvement. If we can go to the next slide. Here's an example of really what their block utilization was. You can see why the hospital was underperforming nationally against national benchmarks. Most of their blocks were well below the 80% norm that we view now as a good benchmark of block utilization. Almost half of them were at 50% or less. So very difficult to maintain the revenue to support the cost structure there. Next slide. When you're looking at your OR, you want to evaluate anesthesia so that because they're so key in driving performance. We want to make sure that anesthesia leadership is engaged, that they actually designate a person and take time out to participate in a daily huddle, that they're driving a culture of safety, that there are consistent protocols as to how they're going to evaluate a patient prior to surgery, and if that patient is cleared by one anesthesiologist prior to the day of surgery, and that patient shows up for surgery the next day and there's a different anesthesiologist there, that they're honoring the protocols of the department and not saying, well, I want to get this extra test or that. What really drives clinical performance is pre-anesthesia testing, and anesthesia needs to own that to make sure that there's a uniform way that we're optimizing patients prior to surgery. We'll talk about it a little bit later. There's a role for the hospitalist there, but the anesthesiologist needs to own it. And you want anesthesiologists that are service-oriented, that aren't ever saying, well, this isn't good for anesthesia. We're not going to stay and do this extra case. They're really focused on the surgeon as the customer, and whatever it takes to meet that surgeon's need, if it's reasonable, they're going to do it, and what's best for the hospital, for the surgeon, and the patient. You don't want anesthesia to argue what's best for anesthesia. You want them to be focused on what's best for the organization. So let's go to the next slide. And what you can see is that this is really the intervention that this organization put into place. They established a collaborative leadership structure. They reallocated blocks. They enhanced the role of anesthesia leadership in driving perioperative performance. They upgraded pre-anesthesia testing, spent a lot of time on supply chain management. They spend time to identify and reach out to splitters, because the splitters are the surgeons that it's easiest to grow volume quickly. They've already got privileges, and for some reason they're just not giving you all of their cases. And what really drives performance increasingly that Alicia's going to spend time on is the ability to get and assemble information, and at the same time that you're assembling information, making sure that the surgeons are paying attention to it. So on the next slide, this is really a good illustration of collaborative leadership structure. We tend to use the name Surgical Services Executive Committee. It's typically chaired by a surgeon. It could be chaired by an anesthesiologist, and in many cases the surgeon functions as the CEO by chairing this committee, but the co-medical director, who's an anesthesiologist, is really participating in the huddle and driving performance on a daily basis. If you can get surgical leadership, nursing, anesthesia, and hospital administration to sit around a table and to agree that we've got to change and we're committed to changing it, that's half the battle. And this is an organizational structure that we've seen increasingly become effective in quaternary facilities, in community hospitals, and rural organizations. This is probably the best format that we've seen in terms of creating cultural change, which really permeates a whole organization. Next slide. And one of the things you might want to start talking about at the Surgical Services Executive Committee is, what are our rules for block? And do we want full day blocks or do we want partial day blocks? There's some organizations that say all we'll do is 8-hour blocks. There's others that are competing with ambulatory surgery centers that might allow a few 4-hour blocks, but it really has an impact on revenue. Particularly full day blocks, what happens is as you move from partial day blocks to full day blocks, you see an increase in hospital revenue because surgeons want the time to really work at your facility. And if they know that they're about to lose their block time because they're not filling it, miraculously they'll bring cases to your organization. In the case of Memorial here, like most hospitals that we've observed, a lot of the growth in volume that occurred from surgeons bringing cases they were doing in freestanding ambulatory surgery centers that they operated on to the hospital. So that not only increased the overall case volume and revenue, but it improved the payer mix because they were really bringing more of their commercial cases there that had a huge impact upon profitability per case. And as you fill up more of your time vertically during the day, your nursing costs per OR minute and other costs go down. So the movement to full-time block time in most organizations, if you don't have a rule and we could go to the next slide, please. If you don't have a rule for 8-hour blocks with a 75 or 80% utilization to maintain blocks, and you move to that, the majority of hospitals, just by changing their block time, will see a 2 to 5% growth in volume and profitability. Obviously, you want to vary your release time by specialty, and you always want to have the ability of the surgeon that doesn't have the volume for block time to get on your schedule, so you can do that increasingly by having 20% of your rooms open rooms. So if it's a 10-room OR, you might block 8 of the rooms and 2 rooms are open, and you can vary it by day of the week, and in some cases even by seasonality. Next slide. The other real opportunity in most organizations to improve profitability is really focusing on non-labor cost. If you look at most OR budgets between space and supplies and material, it's about 60% of the budget. And it's one of those things that you can improve without going through a lot of political battles to get them improved. So if you look at inventory turns nationally in the OR, that means how many times we totally replace our inventory in a year. Nationally, it's about 2 times. But if you look at some of the better performing systems and for-profits, they turn their inventory over almost 10 times a year. So just by focusing on what your par levels are, how much supplies we have in the room, and really focusing on who orders supplies. Not every nurse in the OR should have the ability to order supplies. It should be more centralized. You can have a huge impact on inventory turns and have a huge impact upon your overall cost structure in a very quick manner. The other thing you want to pay attention to is the number of supplies that go up into the OR on a case cart. That's the supplies that go into a room based upon a surgeon's preference cards. If you're seeing at the end of the case that 30% of the supplies are returned as opposed to best practice of 10%, that's consuming a lot of cost and it's a lot of time to put it in the case cart, to take it out, to restock it. It's a lot. Even though national GPO contracts have done a good job in reducing implant costs. If you look at the margin of particularly orthopedics and some of the cardiovascular, there's a 75% margin that the suppliers to hospitals are getting. And if you compare, I recently was able to do some work in Europe and Amsterdam, and it was just very, very interesting to see the same orthopedic implant that we use in this country by one of the more popular suppliers being used there, the exact same implant. It was just half the price that our GPOs here were paying for it. So there's a lot of opportunities to reduce the implant cost even further than we have now. And there's a lot of supplies that we really use as disposable that some of the manufacturing companies will reprocess. And again, it's just a way to reduce costs in such a way that it doesn't upset anybody. Next slide. What really helps to drive organizational performance is this daily huddle, where you're really talking about what went on the previous day and if there were problems, and more importantly, attending to the schedule for the next day or the next 3 days. Is everybody optimized? There's a patient that's the first patient of the day that's going to have a hip implant. They're coming in from a nursing home. They're on Coumadin. You know we're going to want to measure their Coumadin levels before we operate on them. Is that really the best patient to do for the first case, or maybe should we do it the third case? The same with a diabetic. We're going to want to measure their blood sugar level the morning of surgery. You want to have those patients later in the day. We want to make sure that there's the antibiotic that's going to be administered on the chart, and we understand who's going to give it. Those are the types of things that's reviewed in a daily huddle. The key is that anesthesia is involved with nursing, and the pre-anesthesia testing nurses who have spent all that time learning about the patient participate. So the daily huddle along with PAT, the next slide please, are really what is driving clinical and operational performance. This is really where anesthesia gets involved in not only doing testing protocols to make sure that we've got patients who are healthy for surgery, but that they're also managing comorbid diseases. We know that a diabetic has a 40% greater likelihood of a surgical site infection or a complication than a non-diabetic. And a lot of the research by NISQIP and the American College of Surgeons has begun to reveal that we don't want to begin to monitor the diabetic's blood sugar level the morning of surgery, but we want to pay a lot of attention to what their blood sugar level is 2 weeks before surgery. All of these are the types of things that you want anesthesia to set up guidelines and testing protocols for. Most of it could be done by nurses. You would want the evaluation for 80% of the people to be done by phone, and maybe only 20% that would have to come in. If you've got a patient with a lot of comorbidities, while the protocols need to be managed by anesthesia, increasingly hospitals are involving the hospitalist to help optimize that patient because A, they're better trained at managing comorbid diseases, and you want the hospitalist to develop a relationship with a patient that they're going to take care of after surgery. So in the case of Memorial, next slide, you can see that within a year's time, they had about an 8% growth in surgical volume by going through this transformation process. On the OR's P&L, they had a $2.8 million improvement, but because the 8% growth in volume was mostly commercial patients, it had a huge impact on their contractual adjustments and their net revenue. So it really was part of a $20 million turnaround. So I think now we're going to turn it over to Alicia, who's going to spend some time talking about how information can drive performance.
Yes, thank you, Jeff. The Memorial Project was a very interesting project and got significant outcomes, but we want to go through a second project that we worked on that had some pretty dramatic outcomes. Second only to what Jeff was talking about with the Surgical Services Executive Committee and effective communication is that you must have appropriate information and data to drive change. And if surgeons and anesthesiologists do not believe that the data or the information is correct, then they're not going to have confidence in what changes they need to make or even how their performance is going to be measured against their peers, especially going forward with value-based purchasing. Next slide, please. So case time data, which had never been thought of a few years ago, is something that really can drive organizational change. For years in perioperative services in the facilities that I've worked in, we were always measuring turnover time, wheels out to wheels in. We were measuring first case on time starts. We were measuring same-day surgery case cancellations and all of the traditional metrics. But the actual case time, the whole episode of events from the patient coming in to anesthesia being ready, then to cut time, cut to close time, and then to patient out, to the next patient in, was not traditionally being measured. So the case study that we're going to look at now was a large East Coast academic teaching facility. You can go to the next slide, please. And the dean at this organization was really interested in having increased capacity in that OR to the point that he wanted to run perioperative services 24 hours a day, 7 days a week, like I know many of you administrators on this probably would like as well. But surgeons were complaining that they had pent-up capacity and that they had more patients that they could put on the schedule if the hospital would become more efficient. They were also underperforming in some of their key metrics that we'll look at, and leadership was very frustrated because of the bureaucratic situation with all the different service lines and specialties and being able to implement the changes that they wanted and to get those surgeons scheduled for surgery in a timely manner. Next slide, please. So we went into this organization and helped them set up their Surgical Services Executive Committee, and it was physician-driven. Perioperative staff were participating, nursing leadership were participating in the SSEC, but also we set up specific task forces that the SSEC dictated. They wanted a block task force to look and examine, utilizing data, what the block utilization was by each individual surgeon. They wanted a PAT and scheduling task force that would look at what are the protocols. Anesthesia, have you taken the time to determine what is best practice, and are you owning this process, and also are we scheduling our patients appropriately? They also wanted to look at case time because during some of the observations that we had, we saw that based upon the fact that this was an academic facility, they had residents and fellows, that some of their case times were extraordinarily long, and it was variable among many of the specialties, in particular orthopedics, neuro, and cardiovascular surgery. And then we also wanted to look at the efficiency. What was their ability to start their cases on time? What was their turnover times? And they were not meeting national benchmarks. And what was the opportunity to drive a more efficient process so that more cases could be done in every day in each and every OR? So there were physician report cards that the dean wanted, and he wanted a tremendous amount of information, and he wanted to look at what the financial metrics were, what the operational metrics were, and what the clinical metrics were for each surgeon. So next slide, please. This is the physician scorecards that were put together at this organization. Now these first metrics are looking at clinical operations. They're looking at the number of discharges, and these are by surgeon. An average length of stay, what is the length of stay observed versus expected, percent of discharges before noon, discharge designation, where did they go after they were discharged, what is their case mix, and then they also wanted to look at the performance, perioperative performance metrics compared year over year. What was the surgical case volume for inpatient, outpatient, what's the average case time, what's the average case time for inpatient and outpatient surgeries. They also wanted to look at the surgical case times by month of the year. So these were the initial scorecards. And if you'll go to the next slide, please. These are the quality scorecards, and they are based upon data for 30-day readmission rates, surgical site infections, for mortality observed and expected, for postoperative TE and DVT, and as you know, with value-based purchasing and how hospitals are going to be reimbursed. These were the ones that they thought were the most important to them that they measure. Also, they were going to add central line-associated bloodstream infections, so they had a placeholder for that. And then the financial metrics, which are the last ones, included inpatient direct cost per case and ambulatory surgery direct cost per case. So next slide. All of this information was then drilled down and synthesized into a surgeon dashboard that was specific to each surgeon that they received every month. And they could compare where they were for their surgical minutes, for the number of cases that they've done, what type of procedures that they did, also for the minutes that they consumed in the operating room, what was their block utilization, what type of cases compared to the prior month, and also year to date. And so each and every month a surgeon was able to find out and knew exactly what their performance was, and also they developed the opportunity for them to benchmark that to their procedures that are their other clinicians, other surgeons that were doing the same type procedure. So just a second, I've got a computer issue, but you can go to the next slide, please. Okay, case time task force. This is where the work got extremely interesting, because when we did the observations and saw that the case time was longer in some procedures than we had traditionally seen in other organizations, they had an Epic as their electronic medical record system, and there are timestamps that nursing enters. And so we did a lot of training with the nursing staff on entering accurate timestamps and collecting this information. And then the organization was able to extract this data from Epic and look at, this is an example here of vascular service line, look at the minutes from patient in to incision, then from incision start to incision close, and then from incision close to patient out. And they compared it. It was de-identified in the slide that you're looking at now, but in orthopedics, they actually wanted to put the surgeons' names there so that it would drive change among surgeons, so they could look at not only how long the surgeon time was, but also how long anesthesia was taking, getting the patient into the room, getting the patient ready. And anesthesia was able to identify things like, we need to put the blocks in outside of the operating room. We need to be more prepared and more working ahead than taking the patient into the room and wasting all of that time in the room, which can very much frustrate the surgeons. Then surgeons would look at, what can I do? Why is my partner or my colleague taking less time on this procedure than I am? What are things that I can do to speed that up? And then on the back end, once the surgeon's gloves are off and it's time to get the patient out of the room and the surgeon's left the room, how long is it taking to get that patient out of the room and into the PACU? And are there PACU holds that are holding up our efficiency? So drilling down and looking at these type metrics and this type of information can make some very dramatic improvements into your operating room. Next slide. So the things that you would need to do at your hospital to set this up and make this successful is to identify physician champions, because it's essential. Without those physician champions that are willing to look at, enforce, discuss this information with their colleagues, it's going to be hard to be successful. So in this case study in orthopedics, the chairman of orthopedic surgery at a very high-producing orthopedic institution doing 12 joints per day, has a very high national reputation. They were committed by enforcing that the surgeons needed to be in the room at the beginning of the case for positioning and for turnover. And then on cardiac surgery, the head of CV surgery, which was in the beginning one of the slower surgeons compared to his peers, developed a process where he was able to get the data every day, and he would review it with each of the surgeons daily, and they would look for innovative ways to reduce their case time. Next slide. So this institution-wide initiative was able to show that the surgeon in the room or immediately available when the patient is in the room would drive change. They also came up with another very innovative idea, which was anesthesia preference cards. One of the things we heard from the surgeons was it's very frustrating for them when a new anesthesia provider comes into the room. They have no idea what lines, what type of antibiotic, what type of position, and many times that the patient needed to be in, and many times they would have to change the position of the patient and remove the drapes, and so this was extremely frustrating to them. So having all of this information on an anesthesia preference card prepared any anesthesia provider and the nursing staff in the room to be prepared for that surgeon. Adding PAs for complex procedures with significant technology for the setup, and these are procedures like cardiovascular, neurosurgery, robotics. When those were added to the team, and particularly in cardiovascular surgery, there was a tremendous amount of reduction in the time it took to get the patients into the room, ready, and the procedure completed and out of the room. Reduction of items or preference cards. The more you can standardize, the more you can reduce waste, as Jeff has already spoken about, out of the system, also contributes to less time setting up the procedure and less time breaking down the procedure and turning over for the next case. Turnover teams. We firmly believe in turnover teams, and that's one of the things that hospitals have done over the past years, reduced their support personnel. And by doing that, the highest paid individuals in the operating room, such as your RNs and your technicians, are having to spend an incredible amount of time turning over their case and getting ready and set up for the next case. By utilizing lower cost personnel that can turn over these rooms and get it ready, you can reduce your turnover time, which also increases your throughput. And it all comes down, again, to the information, figuring out how you want to display the information, making sure you've got an accurate system in place to obtain that information, and then making sure that decisions are made based upon this accurate information. Next slide. So the impact for CV surgery, they were able to reduce 50 minutes per case in 6 months by going through this process. In urology, they were able to reduce 45 minutes for robotic prostatectomy in case time by going through this process. Now, if you use a very conservative amount of cost per minute, which is $20, I was at OR manager meeting a few weeks ago and learned there that they think the average cost is between $50 and $55 per minute. But look how much you can, with these type of processes, reduce your cost per case and be able to grow your revenue. Next slide. So the outcome, they had a 9% increase in case volume at just their hospital for joint diseases doing orthopedic surgery over the prior year. Looking at case time, adding PAs where they needed, evaluating all of their efficiencies such as turnover, case carts, getting the cases prepared for the room, and 9% increase in some of their highest revenue procedures for the organization. And in addition, they have always been ranked in U.S. News and World Report. Their ranking was at 8, and they were able to increase that or move up to 4. And you know, many of those rankings are based upon their financial improvements, not only based upon their amount of volume. So this process, from a data-driven process, giving them the information and letting them participate in the solutions through the governance structure, really showed dramatic improvement to the organization. Next slide. So I'm going to turn it over to Jeff now to talk a little more about surgical home and what surgical home provides.
Yeah, so increasingly what hospitals are doing is saying for some of our more complex patients, there's a better way to organize how we deliver care to our patients, and by doing that, we can provide a higher level of value not only to the patients but the payers in trying to leverage both our clinical outcomes and costs to get not only more favorable rates but hopefully to help them direct patients. So the next slide, please. What a surgical home is really designed to do is to manage the entire patient's experience, from scheduling to pre-surgical optimization to talking about what goes on during surgery and recovery. And increasingly, our job in looking at the care and the well-being of the patient does not end when that patient is discharged from the hospital, but increasingly what's going on in the first 30 days post-discharge. So what does that mean? Well, let's say you have a patient that is going to have a hip replacement and they're elderly. What a lot of organizations have realized is that if a patient is able to go home rather than a skilled nursing facility, they're going to do better, they're going to be less complications, and they're going to be fewer 30-day readmissions, but not everybody is able to go home with the way that their home is set up now. So what some innovative hospitals are doing is saying when the patient is scheduled and they're of a certain age or meet certain criteria, we're going to have home health go to that home prior to the patient being admitted to the hospital, and let's talk about what we can do to make that home more accessible to for that patient. Do we have to build a ramp, excuse me, so they can get into the front door? Do they need some assistance with their toilet so that it's easier for them to access that and getting up and getting down? Just doing things like that have a huge impact upon the percentage of patients who can go to the home, and then also doing a family evaluation, who's there to support them. That would be sort of a classic example. In addition to talking about their comorbidities, so if a patient is going to have a hip transplant and you know there's going to be a lot of blood loss, are they anemic? And if they are anemic, how we can deal with that prior to surgery so we can try to minimize the number of blood transfusions. So it's looking at this whole process. Next slide. And the way that you go about doing this again is having the surgeons, the nurses, anesthesiologists come together and say, let's look at the entire patient experience and what we can do each step of the way to optimize it. Next slide. So increasingly, there's a lot of work being done by the ASA and the American College of Surgeons on colorectal surgery. A high readmission rate because of the nature of the surgery, a high surgical site infection rate. Well, one of the things that they found that increases that is it's a very painful surgery. After surgery, patients are given opiates to help them manage the pain. So prior to the surgery, both the surgeon and the anesthesiologist talking about the fact that you're going to have pain, you're going to be uncomfortable, but if you could sort of just try to deal with this pain without opiates, you're going to have a better recovery and you're going to be smoother and in the long run more comfortable. Just by having that discussion and helping prepare patients, it not only reduces the number of narcotics that they're given, but allows them to get the patients up immediately in the post-operative recovery phase, and by walking around, it really helps a lot. What they've also found with those patients that there's a lot that we can do with nutrition. So you want to talk about what supplements that patient's going to get 2 days prior to surgery and 2 hours before surgery. Blood sugar, having water with glucose in it will help them. And just having patients chew gum, believe it or not, in the recovery room helps the whole process. We're really systematically saying what impacts outcomes and what we can do to improve it. What's also important is with these complex surgeries with elderly patients, the patients had surgery, they're in a protected environment, the hospital, where everybody's paying attention to them, giving them their medication, and then they go home and all of a sudden they're just overwhelmed with, what do I do? What do I take? How do I manage my blood pressure pill? How do I manage my insulin? So what innovative hospitals have begun to do is that they've coordinated home health so that when the patient is discharged from the hospital, that home health nurse is right there at their home, helping them get settled, reviewing them again with them what their medication schedule is, answering their questions and reassuring them. That has a huge impact upon patients' outcomes and improving the overall process. Also, what's important is a lot of these complications are not just from the surgery, but it's because the patient has not gotten to their primary care physician to talk about their diabetes and their insulin and their hypertensive medication. So helping to coordinate so that there's a primary care visit or at least a discussion with the primary care physician within 24 hours of surgery really helps to improve outcomes. The other thing is not all care in skilled nursing homes is of the level that is what we as healthcare providers would expect for our family members. So what a lot of the more innovative healthcare delivery systems are doing is they're having an advanced practice nurse round on all of the post-surgical patients that are in a skilled nursing facility and making sure that they're getting the right care, that they're getting the right medication, and that has had a huge impact upon outcomes. It's saying again that our job as hospital leaders doesn't end when that patient is discharged from the hospital. Our job is to make sure that our patients get the most outcomes. Next slide. And you can see for some of these surgical home patients that it's really having an impact upon their length of stay, their readmission rates, and it's all because it's more coordinated. I think what we're going to do now is stop and open it up for questions. So thank you again for participating. But I think if we could answer any questions, Alicia and I are happy to do it.
Great. Yeah, thank you, Jeff and Alicia. That was a very informative and enjoyable presentation. So as Jeff said, we'll now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. So the presenters will attempt to answer as many questions as they can during the time we have, and they'll follow up on questions they do not have the opportunity to address. So far, a few questions have come in. Let's see here. So one question here is, are there national benchmarks for service release times for block scheduling?
I'll take that question. Yes, there are benchmarks that we have established based upon the practice in over 550 hospitals, and it is definitely based upon the type of procedure, and it's not the same in every service line, and we would be happy to share those with you if you're interested in that.
So for example, in a more elective procedure like joints, where patients are typically scheduled in advance, the release time for that block might be 14 days. In a specialty where there's a lot more emergent or urgent patients like vascular surgery, the release time might be 1 to 2 days. The key in release time is accommodating the busy, loyal surgeon. So even though there might be for general surgery a release time of, let's say, 3 days, if a general surgeon consistently maintains utilization of their block of 90%, the organization might say for high utilizers of block, they can elect to not have any release time because they know they're going to pick up a patient in the next 12, 24 hours through the ER or through something that comes up on an inpatient unit. So while there's release times, you don't want to make the release times a barrier to getting your loyal surgeons get their patients on the schedule.
Great, thank you both. I'm not sure who wants to take the lead on this next question, but we know some of our surgeon case time is excessive, but we're afraid of the political issues and attempting to address that issue. Do you have any suggestions on how to get started?
Carefully.
Again, I will, carefully. Yes, that's a good point. You do have to designate and identify a surgeon champion. Someone has to be responsible, other than nursing, other than the CEO or senior leadership, to have these difficult conversations and to make sure that they will stand behind that this data is accurate and that there are things that can be done. It is very political. It is very eye-opening. One of the biggest things that happens when you do this is the Hawthorne effect. When you just start measuring it and displaying it, surgeons, as you know, they're not good at working in teams. They like to run the show, and they were never taught to work in teams. But they have always had to be very competitive to get into the best medical school and to work at certain hospitals. So playing upon that competitive nature and displaying that data where they can see that their colleagues, some of their colleagues, are doing things more to drive change as well. But the physician leader is the #1 thing.
Okay, and it looks like we have time for about one more question. Are the majority of anesthesia providers hospital employees, and if so, are they more engaged if they are hospital employees?
I think it's Jeff. I'll answer that. I don't know the percentage of anesthesia providers that are hospital employees or not, but I can honestly say that we've not seen a difference between anesthesiologists who are hospital employees and are just have a service contract with the hospital to provide it in driving change. What we found increasingly is through the work of the ASA, anesthesiologists have figured out that their role is not just to put patients to sleep and to wake them up, but to really assume a leadership role in driving organizational performance. And the key is not all anesthesiologists are leaders, so you've got to identify the anesthesiologist or two within a group who not only has the respect of their surgeon colleagues and their anesthesiologist, but an anesthesiologist that understands collaboration and can really work well with the OR manager. You can really tell if collaborative leadership and governance is working when you ask the anesthesia medical director how they're going to handle a problem, like the surgeon is always late for their first case, and they give you an answer. And then independently, you ask the OR nursing director, and they have the same answer. What happens is they develop a dialogue. They're collaborative in their problem-solving skills, and they're really sharing their skills with one another. And that's what you're really looking for, somebody that's driven by the success of an organization and knows how to bring a team along to achieve this success.
Great. Thanks, Jeff. And for the attendees who did ask a question that we weren't able to get to, Jeff and Alicia will be following up on those questions that they did not have a chance to address. So I just want to thank again Jeff and Alicia. Thank you so much for an excellent presentation, and for all of you who tuned in and listened in today. We look forward to having you join us for future webinars. This concludes today's program. We hope you have a wonderful afternoon. Thank you.